the different types of labral tear can be pretty confusing to patients. You just need to think about the labrum being a bumper that runs around the rim of your shoulder socket. That's called the glenoid. And it deepens the cup a little bit and provides somewhat of a bumper effect to the ball. Superior labral tears are called SLAP lesions, and all that is an acronym. It stands for superior, labrum, anterior, posterior. They're classified into a bunch of different types of SLAP lesions just based on the configuration of the tear. Some of them don't need any treatment. They're very common. They're common in throwers. They're very common in the degenerative middle-aged shoulder, a degenerative type of SLAP lesion. So just because it shows up on the MRI doesn't mean you need surgery. Doesn't mean that you need surgery. But anyway, some of them need to be trimmed, some of them left alone, some of them repaired. I think probably over time, over the past 25 years, we went through a wave of probably repairing and suturing too many of those. And now I think people are a little bit more conservative in the way that they treat superior labral tears. Leave some of them alone, trim some of them, and sure, some need to be repaired. And then as you move around the labrum, anterior labral tears are very common with shoulder instability. When you dislocate your shoulder, there's essentially three things you can damage. You can knock the labrum off, and all the capsule is attached to that. And the capsule is what encases your shoulder joint. Or the labrum can stay intact and you can stretch the capsule, or you can tear the capsule off on the lateral side. That's called a humeral avulsion. That's the least common. So often with shoulder instability to the front, probably 90% of the time there's a labral tear, and that's what you're repairing when you do arthroscopic surgery for shoulder instability, is generally putting the labrum back where it belongs and fixing it there with sutures and anchors that go into the bone. Some anchors are plastic. We generally don't use metal ones anymore. They're either plastic or absorbable, or maybe all suture where they don't show up on an x-ray. And all that does is create an anchor point, kind of like a grappling hook effect, where the suture's anchored into the rim of the socket, and then you can repair it. And you have we have special instruments that we can pass the suture through the labrum. We're generally using permanent sutures or tapes to repair the labrum. They're braided and super strong, almost like braided fishing line. It's very hard to break them. Some techniques involve tying knots. Some techniques involve knotless techniques that are available with modern surgery. Inferior labrums are probably the least common, but they're kind of often associated with labral tears in the front. Kind of where it wraps around the bottom. Ditto for labral tears in the back. Labral tears in the back are common in sports. Throwers get them. Offensive linemen get them. Football players get them. Patients or players that go down on their elbow, or defensive backs or wrestlers, and the ball pistons out the back, and it is associated with instability, but generally the shoulder doesn't dislocate and stay out when it goes out to the back. It just hurts. It pistons out and back in real quick, and the labrum is injured. Usually it's a repetitive type thing. A lot of players play with it for a long time and treat it conservatively before they actually have to have it fixed. So labral tears in any of the quadrants around the glenoid are pretty common, and they're treated differently for different reasons.